Good morning. So very, very quickly before we get started, one, I am Matthew Hart. I am CEO for Longwoods Publishing. Love to network, love to meet everybody. So if I haven't met you before, please feel free to introduce yourself. I'm also on LinkedIn, so happy if you were to find me on LinkedIn. Today should be a very interesting discussion between two very well-known and respected leaders in our healthcare community. I would imagine these two are going to touch on many aspects of our healthcare system and not be afraid to make a few opinions known. You know that I am not one to go into bios and stuff like that, so I won't. I would like to welcome two very close friends to Longwoods, Brian Goldham and Michael Guerriere. All yours.
Thanks, Matt. Good morning. It's Michael, right?
Yes.
Yeah.
Good morning.
Okay. So thanks everyone for joining, and for many of the folks online, we've had an amazing breakfast this morning. So sorry you couldn't join us for that, but more for us. And it always really a pleasure to welcome the healthcare community to the Rothman School. For those who aren't here, you're not able to pick up our new flyer for our Global Executive MBA in Healthcare. And I just have to mention it to make a big announcement. We've just added to the healthcare agenda, not only Toronto, London, and Singapore, but Milan. So the breakfast is even better there. We care very much about the at Rothman Healthcare and Life Sciences. Most people don't imagine that it's a big thing at a business school, but it is the biggest industry in the world, and it's just about the biggest thing we do at the school. So it's a real pleasure to be talking about a sector that I have to admit, embarrassingly, 3 or 4 years ago in my healthcare MBA class, we weren't talking about home care and long-term care. We were talking about hospitals. We were talking about physicians and nursing, but we weren't talking about home care and long-term care. So it doesn't take a PhD for most of us to predict how old 60-year-olds today will be in 20 years. 80 years old, doctor?
Approximately.
Approximately. So it is somewhat shocking that we have, as a society and as a health system planning, not been prepared year after year after year for what's coming at us. So to set the stage, the senior sector has had a very tough few years. And if we extend the demand line and change nothing else, what will the world look like for us around seniors, home care, long-term care, 5, 10, and 15 years? Let's paint the picture of what we're facing if we don't do anything.
Well, it's actually quite easy to paint that picture because we're living it now. We've been talking about this demographic challenge for the last 20 years in the future, and what it's going to do to the system and how complex it's going to be to address it, how challenging it will be to address it. And now we're seeing what it's like. So we're right into that period now where the demand curve is very steep, but at the same time, we're seeing increased retirements because the demographics of the healthcare professionals are the same as the demographics of the general population. So this was long predicted, and so now we're seeing what it looks like. And it looks like big gaps in care, big waiting times, significant health human resources shortages, significant financial stress on the system, financial stress on governments that are trying to deal with it. So it's here now. Now, the problem is that the demographics are still going to get worse over the next 10 to 15 years. The baby boom generation has just hit 75. When you look at the long-term care sector, for example, the average age of admission is 82. So we haven't seen yet the baby boomer impact on long-term care. And so we're seeing now what happens when we fall behind that curve. We have huge waiting lists for long-term care, significant waiting lists for home care, and all of that backs up into hospitals, backs up into emergency departments. So the acute care system isn't working very well either. So I don't think you have to have much of an imagination to know what the demographics are doing for the system, because we're seeing it right now. Unfortunately, the challenge is going to get worse.
So I'm going to go off script already and ask you to distinguish, at least from a market size, demand requirements, home care versus long-term care across the country. How are we allocating our resources there?
Well, the interesting thing about this sector, and it gives you a sense of Brian started by saying that we hadn't really been talking much about long-term care and home care. That's been generally true. And today, the statistics that are available around home care across Canada are woefully inadequate. So I don't have a great answer to that question. The OECD statistics suggest that our spending on long-term care versus home care is skewed in Canada more to long-term care than to home care. I'm not convinced that's entirely true. I think there's a categorization issue in terms of how we're talking about home care and how much of it is for the seniors population. Extended care runs 125 long-term care homes across 3 provinces, and we provide 10 million hours of home care services across 4 provinces. And so we have a sample of the Canadian market. And the vast majority of our home care services are for people over the age of 65. So when I look at the OECD statistics or what CIHI reports, I actually don't think it's an accurate reflection of how we're allocating resources to seniors. But that said, I think it's very clear there's a strong preference among Canadians to have home care services to allow them to stay independent and age at home for as long as possible. I think from a systems perspective, that's preferable as well from a cost perspective. So we really need to understand that question. It's a great question, and I don't have a great answer. But I think that's one of the things when we think about what we need to do to respond to this demographic challenge, we sure need better information about what we're doing today and how effective it is.
So it's fascinating. This is, I think, one other example I'm editorializing of how we may have enough money in the system, but we're allocating it to the most expensive and inappropriate parts of the system. And we'll talk about the broader system in a bit. So let me move on. What are you at Extendicare and others providers doing to modernize the sector and address the demand growth? We've got the problem. What are we doing today? We'll talk about what we need to do later.
Sure. Well, I joined this sector 5 years ago when I joined Extendicare. Prior to that, I had spent my career in hospitals and in acute care and in health technology. So I didn't frankly know that much about the sector. And I was quite surprised actually at the underinvestment in the sector in a variety of ways. Underinvestment from a technology perspective, a real reliance on manual, very slow, very manual processes. An underinvestment in infrastructure, certainly the buildings that we're providing long-term care in are aging. Many of them are 50 and 60 years old. So again, underinvestment. And I was really surprised at the staffing levels for long-term care, which were 2.8 hours of direct care per resident day against I think a reasonable international consensus that average should be somewhere over 4 hours. So really surprised at how people were making do with very little, and so very inefficient system, and a system that was starved for funds. You started off our talk today by saying last few years have been really difficult. Actually, the last 15 or 20 years, I think, for the sector have been very, very difficult. The pandemic was a huge wake-up call, and governments across the country have responded to that. So 4 hours of care per resident day seems to now be the floor. Many provinces are 4.1, 4.2. So there's been a 30% increase in funding for staffing levels. And also some very significant increases for salaries and compensation as well. So we are in a catch-up phase across the country in terms of getting the quality to where it needs to be. And we're building huge numbers of beds to catch up. In Ontario, there's 11,000 beds under construction as we speak, with the government targeting 58,000 beds over the next few years. But that's against a waiting list of over 40,000 people for long-term care. So we are still behind the curve. We're in a catch-up mode, and it is a really, really challenging time from a hiring perspective. So, what do we have to do to meet that challenge? What's the sector doing? First of all, we need to get really good at training people. We need to get a lot better at that. All of our organizations have to be part of increasing the supply of health human resources. Our partnerships with colleges, with universities to educate the next cohorts really have to be front and center in our planning and our investments. And then we need technology, because the tools that we're giving people are inadequate to do their jobs. And so there's big investments happening in that area. We can talk a little bit more about that. So I think the modernization is underway, but because we're so far behind the curve, it's hard to see evidence of that at the moment.
So I'm going to extend this a little bit. About 10 days ago, I brought a group of students to Singapore. So a country with the longest life expectancy at birth. And this issue isn't part of their discussion around challenges. I know many of the Asian countries, because of life expectancy and also the family structure, have been great innovators around long-term care and home care. Are there lessons you can take, you and your colleagues and across the sector can take from other countries? And some of these are, like Singapore, very urban and very concentrated, but some others are not. They're quite dispersed.
So this question is what's known as a leading question. It's a great question. Of course,
The answer is yes.
Of course,
but-
the answer is yes. And the best way to get that is to sign up for the
No.
MBA program at Rotman.
That was not the intention.
But actually, it is the right answer. There are a lot of exemplars around the world that we could be looking to. And you don't have to go all the way to Singapore. I would argue that there are some exemplars in Canada of really good models that are working really well. We talk a lot about reforming family practice and primary care, and what we need to do on that front. We talk about, gee, that involves multidisciplinary care and bringing a more holistic approach to providing primary care that's available 7/24, care that's technology enabled. There are practices that operate just like that within 10 kilometers of where we're sitting right now. So there are lots of examples of this in the Canadian setting. The problem is that they're not the only primary care operations that are operating at the moment. And we have trouble in our public system with the idea of creative destruction. Okay, this idea that better business models should replace and supplant weaker business models over time. In order for that to happen, the weak business models have to go out of business. We don't do that well. We don't even provide financial incentives that help that along and help that to happen. So you've got these outstanding, excellent primary care practices operating across the street from walk-in clinics that have no continuity, no connectivity, etc. So one of the challenges that we have is to measure performance, report it publicly, and be able to support those business models that are more effective. And there's a lot at stake around this. If we don't do this, our public system is going to continue to disappoint the public. Our publicly funded system is going to disappoint the public, and you start to see support for that government-paid model eroding. We're seeing that now. We need to protect that. But in order to protect it, we're going to have to get very serious about rewarding those programs that are working well and defunding those programs that don't work well. Defunding is a really tough thing for governments to do because it looks like they're defunding healthcare, and there's all kinds of criticism when that kind of thing happens. But we're going to have to do it. We're absolutely going to have to do it. We have to get more productive and more effective in the way that we're providing care. Because if we're stuck in the old paradigms that are 20 and 30 and 40 years old, we're not going to transition and deal with this demographic challenge effectively. So it's a tough call, but we're going to have to do it.
So we're going to come to discussions about funding models and competition and reallocation in a bit. I don't want to get too far off innovation, but they're obviously connected. There need to be investments. Given the health human resource challenges, both shortage, at least in the short term, until we can improve capacity, what are alternatives around technology? So, for instance, one of my colleagues who you know well, Avi Goldfarb, has invested heavily in AI research in healthcare, has a book called Prediction Machines. And it seems that across the sector, we're not very good at predicting not only long-term, but maybe even predicting the needs of a patient who you're not seeing every day, or not, and predicting how many hours they need to be, you need to spend with them. So I'm going to get far into the world here, but not so far into the world elsewhere. The role of AI, the role of robots. Go crazy.
Well, the issue of technology in healthcare is tied up with the point I made earlier on business models. Technology enables different business models, better business models. And when I say business, I'm saying that because I'm in a business school.
You're in a school of management.
If I were in the medical school, I would be talking about models of care. But it's the same concept. Technology enables different models of care and different approaches. And so if you don't allow the business model to evolve, any technology that you bring to healthcare isn't really going to advance our situation. So, I mean, we can talk about AI and the excitement around it, and I'm very optimistic about some of the things that will enable. But, you know, I think we should also talk about the idea that we could use email in healthcare, like technologies that are old. You know, we've moved on from, you know, in most service industries, we've moved on from taking orders over the phone and scheduling things over the phone. We've moved on from voicemail. We've moved on from using fax machines, but not in healthcare. So let me just quick poll of the audience just to make a point. How many people in the past year have booked a trip online, some kind of travel arrangements? And how many people have booked an appointment with your family doctor online? Okay, so see, it's about half the hands. So these are technologies that are 20 years old. These are not some kind of new concept. So the thing that's interesting about that show of hands is two things. Is one, that there's a huge number of people who didn't put their hand up. So they're still making phone calls to book an appointment with their doctor. I'm one of them, by the way. And it's one of the University Avenue hospitals that should be nameless. But the other interesting thing is that there are a whole bunch of people who did put up their hand. And so you would think that the better service would win, and that people would say, well, I'm not going to put up with this. I'm going to move over here. But our system doesn't have that flexibility to have funds following the patient. You can see the disempowerment of individuals to make choices to get better service. We don't allow that in our system. It's all part of that whole discussion about business models and allowing business models to fail. The way that happens is if people can choose where the service is best. And so unless we empower the patients and the general population to make choices around healthcare and where they're getting better service, and have the money follow them, then we're going to still have this problem of very, very slow adoption. When we go to international examples, they've set up one of two models to get this to work. Either a Singaporean kind of situation where, essentially a benign dictatorship dictates what's going to happen, or there's a model where there is a market that drives those changes. So we need to be thinking about how to unleash those kinds of ideas to be able to drive faster reform in our system.
I think it's called a one-party democracy that's been in power for 60 years. This conversation about choosing, patients choosing, customers, clients choosing is music to my ears. When I speak to my students who have no exposure to healthcare, I ask them, how many of you have a great physician or a great healthcare provider? They all raise their hand. I ask the question, how do you know? They can't answer that question. The question then is, how can we design or redesign our system so that there's sufficient information available in what you would need in any market, even a non-profit market, for choice? What's the basis of those decisions that customers and clients, patients will have?
I think we have a bit of a tendency in healthcare to focus more on what the provider organizations judge to be good quality of care, as opposed to what the individual judges to be good quality. And it's a hazard. It's a hazard because, we want to be supportive of individuals, of the people in our care. That's what we're trained to do as clinicians. But it's not necessarily a model that's responsive then to, to their experience. I think that people's individual experience is really important in that. I'm not sure that people are going to go onto websites and look at objective quality measures and that sort of stuff and say, well, I'm going here because the mortality rate is lower than it is over here. I think the relationships that people have with their caregivers are a really important part of this, and we need to respect that and allow people to have some choice. We're now at a point in the cycle, of course, where the quality is dominated by access concerns. Like people are just happy to have any physician. People are happy to have any access to the healthcare system. So they're really disempowered in that kind of a situation where they're not, they're not able to even get a second opinion on something that they're really not sure about.
Let me move to the issue of public and private, and I'll use an example. So I believe nearly all of extended care revenues for your home care operations through ParaMed come from public sources. You're an investor-owned, shareholder-owned company. Your shareholders have many options, Tesla or extended care. How, with the constraints on public funding, 99% of which of your revenues are coming from the public source, how do you have a conversation with your investors that they can earn a reasonable return when there are such constraints on your revenue?
Yeah, this is a critical point in the whole discussion about the role of for-profit operators in healthcare. The first thing I want to just make sure that we're all talking about the same thing is there's a big difference between for-profit operators and charging the public for services. So Brian's point is a critical point. We have all of our revenue coming from government-paid services. We are a for-profit entity, but we only provide publicly funded services in our organization. So, my view is that a publicly funded model is far superior for a whole bunch of different reasons. And I think there's a broad Canadian consensus about that. So what then is the role of a private operator in a public system? And I think the word that you used, Brian, is really important, which is a return. Okay, so the question is return on what? Well, return on an investment. I mean, the shareholders or the bondholders of a company are making an investment in healthcare. In our case, the investment is in building new long-term care homes. I talked about the homes that are being built. Extended care has about 1,500 beds under construction at the moment at a cost of about $700 million. We've got another 4 homes starting construction this year, cost of another $400 million. So these are funds that are coming from private markets and are coming to, into the sector. So when you look at the way our shares work, we pay dividends. We've paid the same dividends since 2015. Our yield is about 6.5%. And that's very, very similar to what you would pay on a mortgage. What a not-for-profit long-term care home would pay on a mortgage in order to build a new home. So it's a return on investment. It's a way of getting access to capital for the healthcare system. Now, in a perfect world, I would much prefer to see healthcare being a not-for-profit enterprise. But that would mean that our capital needs would have to come from donors. And that's just not practical, given the challenges that we need in terms of investment in the sector. So this is something that governments have realized. And so a mixed model where there are providers of long-term care that are for-profit, that are not-for-profit, that are municipally owned. Some of them are hospital-owned. So there's a wide variety of operators of homes. And all of us, whether not-for-profit, for-profit, municipal, are tapping into markets to get the capital to build homes. That may be in the form of shares in the case of extended care. It may be in the form of mortgages in the case of not-for-profits. Municipalities can tap into the government bond market. So we're all bringing private capital and paying a return on that capital to make it possible. So as long as we're all paid in the same way, regulated in the same way, this is a reasonable way to address the capital needs of the sector.
So I think you made the important point, publicly funded, and whoever can step up and deliver quality and access is critical. Are there advantages in terms of flexibility or funding models in the private sector that make the private sector a critical part of this multi-pronged approach to funding the sector? Are there things you can do that municipalities or provincial or federal governments can't do?
Yeah, this is a great question. So one of the things that private entities can do is operate in more than one province. So one of the big challenges we have in healthcare in Canada is that we operate at a subnational level. We're actually the only country in the OECD that runs healthcare at a subnational level. And this is a big disadvantage because we have a very fragmented market. And I can tell you, operating in multiple provinces, that all of them have different information standards, funding models, regulations. They're all different. And I can tell you that the residents in the long-term care homes and the patients that are being taken care of, their physiology is pretty much the same, province to province. Like there's no value in the differences that are there across the different provinces. So scale is very helpful. It's one of the things that Extendicare is now offering to smaller operators across Canada. So we purchase for municipal homes, not-for-profit homes, for hospital homes, and our purchasing collective now buys for about 130,000 beds across the country. So that ability to aggregate demand for food, for supplies, for equipment is allowing us to bring a lower price option to the entire sector. Similarly for technology, and this is one of the things, it's really been interesting to me why the Canadian healthcare system, which arguably in the 1980s, when I went to med school, I think you could make a pretty strong argument back then that the Canadian system was, if not the best healthcare system in the world, in the top 2 or 3. So what happened to us? If you look at the spending that we've done on healthcare, we're spending as a percent of our GDP among the highest in the world. So it's not that we've underfunded the system. What happened? Well, I think the thing that advantaged us back in the 60s and 70s and 80s, which was smaller healthcare systems that were very close to the patient, very localized, is now disadvantaging us because we're in a world where technology is now playing a huge part in the quality of care and how care is delivered. And it is tough to amass enough volume to make the investments in healthcare that you need to make. You think about what's happening in this province, for instance, hospitals are banding together to put Epic in or Cerner in as their big electronic medical record systems. But I would argue even those groups are not big enough. Brian and I take the MBA class to Kaiser Permanente in California to spend a day and looking at their model and how they operate. They use the same system that we do in many hospitals across Ontario, but they have one system for 12 million people. So they have one Epic system for a population the size of this province. And as a result, what they're able to do with that system, what we're doing pales in comparison. Even though we are using the same technology, we don't have the scale to be able to make the investments in technology that are necessary to get the business model improvements, the productivity improvements, the quality improvements that they're able to get. So anyways, coming back to your question, That was a long digression, but having scale and being able to bridge provincial boundaries, I think, is a very important contributor to how the Canadian system evolves.
I'm going to shift gears again. And demographers talk about the dependency ratio, essentially the numbers in our community who are working, contributing to the tax base relative to those who need more support. And immigration plays a mix in this. Now, I'm not a demographer. My sense is immigrants coming to Canada tend to be younger. Where does immigration fit into this mix of both demand and potential supply of health human resources?
Well, I think we're in the midst of a pretty big experiment, and I don't think it's going very well. I mean, I think immigration is an area of which Canadians can be justifiably proud. We've been one of the most welcoming countries in the world. But I think it's pretty clear that immigration, at least by itself, is not going to resolve our demographic challenge. I think it can help. It can help to relieve some pressure on the system by bringing new Canadians to help with meeting care demand. But it is it's not going to solve the cost equation. And Brian, you talked about the dependency ratio. We're seeing that dependency ratio getting worse over time as there are more and more people in the seniors demographic who aren't working but needing support and needing services. So, what is going to address that issue? I mean, one of the big discussions we're having in Canada right now is how our productivity is lagging and how our efficiency is not improving. In fact, our GDP per capita is dropping. We need to get serious about this in healthcare because I don't think we're going to be able to afford a system that works the way today's system works. We're going to have to make some big shifts to improve productivity. So, the next question is, okay, well, how are you going to, people usually look at that and say, well, how are you going to make people work harder and do more? Well, there's a couple of areas where I think we have a huge opportunity. First of all, there's a lot of focus on doctors and nurses and care providers in the system, and justifiably so. And they're stressed, and they're certainly facing some significant challenges. We don't spend a lot of time talking about all the other people that are working in the health system, and there's a lot of them. And that's where there's a huge productivity opportunity. Things like scheduling and automating the way the public interacts with the healthcare system. Our online systems in healthcare are woefully inadequate. Like just the issue we talked about earlier in terms of being able to book an appointment and to be able to book an appointment efficiently so that those appointments are actually, well organized. In home care, as an example, talked about Extendicare doing 10 million visits in the last year. We schedule all of those manually. So I have almost 400 people working for Extendicare who are in cubicles manually scheduling those visits. Now, they're computer enabled, so there is some aspect of it that is automated, but there's no ability for all of our clients to be able to see when those visits are, when somebody's going to show up at their door, et cetera. So the only way that we can communicate that is on the phone. And so we have call centers that are taking calls from people. Now you can imagine how excited people are with that level of customer service. So we are in the process of automating that entire activity. We're making very good progress on that. But when you talk about AI, I think these are the areas where we can make huge gains. And I'd argue that hospitals, doctors' offices, et cetera, all have opportunities to automate significant parts of what they're doing. And then if you actually go into the care areas and think about that a little bit, when you think about it, when you interact with any service, whether it be a bank, whether it be a travel, provider, airline, et cetera, who's doing a lot of the clerical work for those companies? You are. You go on, you do all the transactions, right? You're online and doing a lot of that work. What's the analogous kind of situation in healthcare to that? Where do we have people involved in actually documenting their own care and being part of that? There's a company, a startup in Toronto called First HX that is a really interesting technology. If you haven't looked at it, take a look at it. They're making good progress in automating the whole history taking aspect so that when the patient goes in to see the doctor or the nurse practitioner for the first time, most of their history has already been documented so that they can move right to kind of diagnosis and therapeutic decisions, as opposed to spending a whole bunch of time with a doctor typing into a medical record system. These are the kinds of things that are huge productivity steps. And now with AI options and that sort of stuff, the opportunity to do this in a major way and to reduce workload in a dramatic fashion is now available to us.
Maybe my last question. We have spent 20 years talking about what can we do to improve the system, the broader system. And a lot of our conversations have been around primary care, acute care, and more recently home care, long-term care, but they're all, of course, related. If you had the Rothman magic wand or the extended care magic wand, what would be the 5 things you would wish to be true?
Another leading question to end the event, but I honestly, I think the first thing I would say is we need to invest more in management education in healthcare.
That was not planned.
And certainly something we're doing, but specifically what do we need our managers to be better at? Certainly analytics and managing data, managing technology and technology implementation, workflow analysis, and improving performance. Those kinds of things are table stakes in most industries, not part of the DNA in healthcare. We've got to move in that direction. Secondly, our technology investments are woefully inadequate. We're way underinvested in health technology. We need to move forward with that. Third, transparency and reporting of data and performance needs to be an absolute cultural objective across the whole system. It's a huge opportunity for us to know what good looks like, compare good to mediocre, and make sure that the funding is going in the direction of the good. And then finally, we need to move money. We need to make sure that the finances are incenting those models that are working the best.
So it may have been a leading question, but it wasn't intended. But I just want to observe that all of your fixes, short-term and long-term, with all respect to the scientists and clinicians in the room, had nothing to do with improving the science or our clinical expertise. It was all about building a better system so our exceptional clinicians and caregivers can work in a more effective system. Mike, as someone who will be a client sooner than I would like to be, I want to thank you. We're going to open this up to questions from the audience. I'm going to pass virtual audience and to our audience in the Rothman room. I'm going to pass it over to Matt Hart to moderate.
Thank you. Very, very quickly, I was one of the people that put their hand up for, I have booked an appointment with my doctor online. And he is, I think, ahead of the curve in Canada, which is also way behind the curve everywhere else in the world. So I just thought that was interesting that, you know, I mean, we had enough, I think you said about 50% of the people in the room put their hand up for that. So we have a number of questions. I'm not going to direct them to any one person. You can both choose to answer. And I'll try to see whether or not I can group them together. The first one I'm going to kind of go with is there's a lot of questions about defunding. I'm not a fan of that word. I prefer reallocation. But taking policy out, taking red tape out, how would you kind of reallocate funds? Where would you like to see money go versus where, you know, and then have money removed?
Well, I'll start. So I think we got to be careful not to think that the solutions to what's a centrally planned kind of system are going to come from the center. So, you know, very specifically, I think we've got to be careful not to wait for government to design the healthcare system of the future. Because I think we're going to be waiting a long time. And so I think avoiding that, you know, that temptation to wait for someone else to solve the problem is really important. So, you know, you look to different people in our, you know, in our system that are moving forward, advancing the game, doing it without waiting for government to, you know, to move forward. So examples, you know, recently it was announced that West Park is merging with UHN. So there's an example of where two leaders, Anne-Marie Malik, Kevin Smith, got together with their boards, thought about what could happen and what was possible for the future, and they brought solutions forward, and the government said, absolutely, let's go. And very exciting what's happening in terms of rehab and what's possible because of the network that's forming there. And oh, by the way, they're using an excellent information system to underpin that whole operation. So, you know, then you see, you know, what Trillium has done with their long-term care. They built this new long-term care tower, an excellent example of what's possible in terms of two sectors, you know, bridging back and forth. So acute care, long-term care, working more closely together. We didn't talk much about that, but that's a real opportunity that a number of hospitals are advancing. And we have the pleasure of working with 6 hospitals now across the province on building new long-term care models. So, you know, not waiting. But that said, you know, I think there's an opportunity for leaders in different sectors to come together and to put forward their ideas for modernization and proposals for better ways to use the funds. And I have found governments to be incredibly receptive to those kinds of ideas.
And I will speak very briefly at a higher level. We have never defunded the health system in the 30 years almost that I've been in Canada. Our funding has always gone up. Reallocation is the right word. And for those in the room and in the audience who are interested in home care and long-term care, that is clearly the place where we get more value than many of the spends that we do in other parts of the system. So the language we use around here is value. How are we going to take the dollars that we are currently spending and get more and better care? And that requires reallocation. And I think more and more it's going to be to home care and long-term care.
Again, so just grouping questions together, there are a number of questions about HHR. The one that I'll kind of go towards is, how do you address, or what's your vision in addressing the northern communities and the rural communities, all right, who have, one, difficult getting people to work for them, and two, difficult retaining them?
Yeah, we operate home care across the entire province. So in every corner of Ontario, we have home care workers. So we face this challenge. We also have long-term care homes in Timmins, in Kapuskasing, in all kinds of different parts of the province. So this is a very real challenge. You know, a couple of things that I would say. First of all, local training programs that are training people in those communities who want to be part of the care community. That's a huge opportunity. Creating training programs that allow people to work while they're getting new credentials is a major part of something that we're moving forward with. The government's been incredibly supportive with funds for those programs. The colleges have been all over it. Like I just find there's people ready to come together to solve these issues. So I'm very excited about what's happening there. And then the last thing, not the first thing, but the last thing that we've used in some communities very effectively is bringing a cohort of new Canadians into that community to address an acute healthcare need. The federal government has put together a number of programs that allow that to happen and make that possible. And we've found that, you know, we've really been able to quickly solve, you know, certain challenges in some communities by using that mechanism.
So we're just about out of time, so we'll do one last question here. And again, I'll kind of leave this as an open question and you address it how you feel. Modernizing our model of care, prioritizing the patient. How do we move forward? What's your vision for what's down the future in the next 5 to 10 years? The shortest possible answer.
Let me start.
You start.
Let me start. More transparency around outcomes, so patients, clients, and families can choose the best and the most appropriate care. We need to invest in that, and we need to make that information available broadly.
Yeah, and I would extend that by just talking about the need to partner with families more effectively. It's one of the things that we're focused on in terms of our technology solutions, is making it possible for patients and their families to access their records, communicate with care providers, do so easily with texts, with emails, to be able to contribute to and understand what's happening. Those points of communication, like we've set up so many barriers that make it hard for doctors and patients to talk to each other, and hospitals to communicate with their patients, or hospitals to communicate with home care providers. We're really operating in silos, and we all talk to the patient to find out what's happening, because we're not, you know, easily able to talk to each other. So those communication systems and the way that we organize ourselves around communicating with patients and families and other members of the care team is really a key aspect of how we're going to modernize and improve the system going forward.
So that's it. And I will give you one last opportunity, if at all, to address any last things, any last comments. Other than that, I would like to thank everybody for a wonderful day.